Good morning, everybody. This is the January 28th, 2020 hearing for the Health Committee. I'm Councilman Christopher Burnett, Chairman of the committee. Also in attendance, committee members Bill Henry, representing the 4th District, Mary Pat Clark, representing the 14th District, Councilmember Reisinger, representing the 10th District.
Thank you, Mr. Chair.
We are also joined by Nina Themlis from the Mayor's Office, Rebecca Simmons from Council Attorney of the President's Office, Scott Davis, Council President's Office, Caitlin Young, Council President's Office, and to my immediate right is Marguerite Curran, the committee staff person. Today is an informational hearing that pertains to aging and chronic disease. So we'll be hearing presentations primarily from the health department, but we do have some outside partners as well that will be presenting their work. So we'll get right to it. First up, we have a presentation from Jeff Ambrose, Senior Director of External Affairs at the Baltimore City Health Department. And if you want, you can introduce your team.
Sure.
Or have them introduce themselves so we know who's in the room.
Sure. Good evening, Mr. Chair and members of the committee. Good morning. Good evening.
Good morning.
Backwards here. As you can see, we don't travel light at the health department, so yeah, we've got quite the crew today. But I apologize. I'm subbing in for Deputy Commissioner Mary Beth Holler, who's ill today. So I'll just be teeing things up and then having the rest of our team actually present the information and data. First, we'll have Darcy Phelan Emmerich, our chief epidemiologist, presenting data on chronic disease throughout the city of Baltimore. Then we'll have Kamala Green, our Director of Health Promotion and Disease Prevention, and Margaret Schnitzer, our Director of Community Asthma Programs, presenting on their specific portfolios within chronic disease. So with that, I will let Darcy take it away.
Good morning, everyone.
Morning.
Again, my name is Darcy Phelan Emmerich, and I'm the Chief Epidemiologist with the City Health Department. I'm so pleased to be here this morning to speak with you about chronic diseases. So I thought we could start by first taking a look at what are chronic diseases exactly. And they're diseases that are defined as lasting 1 year or more, and that require ongoing medical attention or that limit the activities of daily living. So they're really persistent diseases that have an impact on our healthcare system and on a person's activities of daily living. Some examples of chronic diseases, these will sound familiar to you: heart disease, cancer, stroke, diabetes, chronic lung disease, asthma, Alzheimer's disease, and chronic kidney disease. And so we want to ask ourselves, why are chronic diseases important? Well, as we'll see in just a moment with some data from the city, they're the leading cause of death and disability. They affect a large number of people, of course, and they explain some of the differences in life expectancy by race and sex that we see in Baltimore City, and I'll show you those data. And chronic diseases are also expensive to people as individuals as well as to the healthcare system. This is a graph of leading causes of death in Baltimore City for the year 2018. And you can see on the right, we have the largest number, about 1,900 deaths due to heart disease, stroke, and other cardiovascular diseases. That's followed by about 1,300 deaths due to cancer. And then on down the graph to the right, you can see the other causes of death. When we look at these data through the lens of chronic diseases, we can see here I've shaded everything in red that's a chronic disease. So that includes our 2 leading causes of death: heart disease, cardiovascular disease, followed by cancer. On down the line with diabetes, chronic lower respiratory diseases, kidney disease, as well as Alzheimer's disease. And so when I looked at the data through this lens and just did some simple math, I added up the number of chronic diseases and deaths due to chronic diseases and divided by the total, and found that nearly 60% of deaths in Baltimore are due to chronic diseases. So 60% of deaths in Baltimore due to chronic diseases. That's a huge number.
You know, when you think of it.
In Baltimore City, analyses that we've done, yes.
Could you, do we have a hard copy of this?
Yeah, this is real.
Yeah, because
I just say,
could you
for
go
the
back
old
to that
people amongst us.
chart of the total number of deaths from each cause? Because I think I want to take a picture of that.
Certainly, certainly. So I can actually tell you the added up numbers themselves. So in 2018, there were 6,753 deaths in Baltimore City. And that's a usual number. We usually see between 6,000 and 8,000 deaths in the city. And then just based on adding up these diseases here in red, that adds up to 3,895. So when you take the 3,895 and divide by that total of 6,753, you get 57.7%.
Of the deaths are from chronic disease.
Of deaths in Baltimore City that are due to chronic diseases like heart disease, cancer, stroke, diabetes, and on down the list.
Are we allowed to ask a question?
Yeah. I mean, we would usually like to wait to the end of the presentation, but go for it.
Okay.
Yeah, go for it.
Oh, how did people die in the other 40%? I mean, were they all old? Are these all old people?
So these are
Whatever that is?
These are all of the deaths in the city, so regardless of age. And so when you look here, you can see that the third leading cause of death is injuries. That includes poisonings as well as overdoses.
Hard to see. So is that that's the third? Really? After the two top chronics
Yep,
is what?
is injury. So injury and followed by accidents. So injury and accidents. So that would include overdose as poisonings as a leading cause of death and different types of accidents. And then, of course, followed by homicide.
Oh, so,
Councilman Henry?
okay.
And we're gonna be having a hearing about overdose, I believe, on February 12th.
So overdose counts as other injury or accident?
Here, overdose counts in the category of other injury.
Me.
Okay.
So the graph is cut off, but it says other injury includes poisonings.
Includes poisonings, and then accident says non-motor vehicle.
Yes,
So motor vehicle accident is a separate category,
Yes.
not on this chart.
correct. It's further down the line.
76.
Yep.
Okay.
Yep.
I was just curious if for the other injury that isn't an accident, but it isn't a homicide, so that's basically overdoses.
A lot of those are overdoses, but they could be things like falls. Person can be seriously injured. Falls are the leading cause of.
But then what's an accident?
Of what?
An accident can be a fall, or it could be getting injured in another manner.
Okay.
I'd be happy, I can provide
I
clarification.
think, if we could get this chart with very clear delineations of what
Okay.
each of this got. I'm just looking at the stark difference between, say, for example, the number of homicides and the number of deaths from the various other things. Okay.
Which one is that?
It's the fifth one over.
Which one?
The fifth
Fifth?
line over?
Yeah, so, well, I guess it doesn't show up on the slide. But
Marguerite's making copies. So we'll have copies. We'll have printouts in a second.
And some of those falls, may I just say this? I mean, everybody in the worrying about the aging is worrying about falls. So when you say falls, or maybe when you say
Yep.
accidents, I don't know what you're saying.
yeah, I think here falls would be included in the accidents, so the fourth leading cause of death in this slide.
Oh,
But I'd be happy to do a breakdown for
that'd be good.
the
when you're-
committee, yep, to show you within those categories, how it breaks out.
Because we're supposed to be paying attention to that as a city.
Yes,
That the health department told us to pay attention to.
yes,
falls.
falls do,
And so it'd be good to see how they break out of those accidents.
sure. Yep, I would be happy to provide the committee with that information. Okay, so as we said, chronic diseases account for about 60% of deaths in Baltimore City. And I also wanted to just briefly mention about disparities in life expectancy. So at the health department, we do analyses looking at differences in life expectancy by both race and by sex. And when we look at the causes of death that drive these differences in life expectancy, we can break them out by which are the driving causes of death that account for these differences in life expectancy. And so you can see on the graph, represented in the light blue at the bottom of the columns, heart disease, followed by cancer, homicide, and then other causes of death. What I'd like to highlight here is that when you take into account chronic diseases like heart disease and cancer, that accounts for 31% of the difference in life expectancy by race in the city. So chronic diseases account for 31% of the difference in life expectancy by race in Baltimore City. And by sex, these chronic diseases account for 36% of the difference. So for instance, in Baltimore, there is an 8.3-year difference in life expectancy between male and female residents. Female residents live longer, so there's an 8.3-year difference. Chronic diseases account for 36% of that difference. When we look at it by race, black versus white, we find that chronic diseases account for 30% of that difference. The next slide here presents cancer mortality rates calculated by community statistical areas. And community statistical areas are groupings of census tracts that approximate neighborhoods. So we have cancer mortality rates by community statistical area, and we've overlaid city council districts. So the darker colors here indicate higher cancer mortality rates, and these are mortality rates for all types of cancers combined together. And so you can see we have dark shades both on the west side of Baltimore as well as on the east side. And again, the darker shades are the higher cancer mortality rates. Cancer being our second leading cause of death in the city, as well as being a chronic disease. So in asking ourselves what causes chronic disease, our risk factors include smoking. So smoking is the #1 leading preventable risk factor in terms of chronic diseases, including exposure to secondhand smoke, which can also exacerbate asthma. Lack of physical activity includes as one of the risk factors as well. And then poor nutrition and obesity. I know that we'll be having a hearing devoted to nutrition and obesity, I believe on February 11th. So you'll hear much more information then. I wanted to give you a sense of smoking, what the distribution of smoking looks like by age group in Baltimore City. So overall in the city, among all ages, our prevalence of smoking is 22%. So 22% of adult residents in Baltimore City are estimated to be current smokers. We can see this differs, though, when we look at it by age, with the highest prevalence of smoking at about 1/3 in the age category of 45 to 54-year-olds. Okay, and that decreases as people get older. You can see the lowest prevalence of smoking is among 65 or older. But across the city, the overall prevalence is 22%. So I'd like to mention, too, that across Maryland as a whole, the prevalence of smoking is 14%. So here in the city, we average 22%. Maryland as a whole averages 14% for current smoking among older adults.
Just a quick clarification. 14% among older adults?
No, among all adults.
Among all adults.
All
Right.
adults for the state, yep, versus 22% among all adults here in the city. So that's quite a big difference. And then Here is a map of the projected prevalence of smoking and by census tract, and then overlaid with city council districts. And so you can see really the darkest shades. The darkest shade there represents a prevalence of smoking from 28% to 38% of adults.
I can't see my district.
And so,
And it doesn't smoke a lot.
and so you can see the darkest colors are on the west side and run south. And then we see darker colors again on the east side. And again, the darker the color, the higher the prevalence of current smoking.
That's people. You guys are smoking like chimneys.
So that gives you a sense of smoking. And the other risk factor I mentioned is physical activity. And so here we have lack of physical activity by educational status. And I'd like to point out here that physical activity, this is measured as 0 minutes of physical activity per week here. And it shows us that in Baltimore, among adult residents, those with a college degree report about 20% of having no physical activity in a given week. And that's versus 50% for those adults who have less than a high school diploma. So it's almost a twofold, well, it's more than a twofold difference between those groups. So physical inactivity is a risk factor for chronic diseases. And here we see the highest prevalence of this risk factor is most common among adults who have less than a high school diploma. And so with that, I would like to invite my colleagues from the Division of Chronic Diseases to speak about the services. And if you have any questions about the data, I'd be happy to answer them maybe at the end of the chronic disease session or whenever it's convenient. So thank you.
Thank you.
Good morning, everyone. Kamala Green from Baltimore City Health Department, Director of the Office of Health Promotion and Disease Prevention. So our office is solely responsible for the prevention of and the control of chronic diseases. So we do data surveillance, direct services, as well as coalition building. So under that portfolio are a couple of different programs, which are virtual supermarket, well, which is Baltimore Market, which is responsible for virtual supermarket, healthy stores, food justice forum, nutrition education. And then you have Tobacco Free Baltimore, which is tobacco enforcement, tobacco prevention, use cessation, and the Baltimore City Tobacco Cancer Coalition. So I noticed that you all were looking quite intensely at the data that was given to us through the map. So let me just briefly give you some statistics as we talk about virtual supermarket. So as we identified in several of the maps around chronic disease, there are what we call healthy food priority areas. And so in those, yeah, it is in there. In the healthy food, it's next to the last set of slides. So if you flip back and come forward, you'll see them. The healthy food priority areas in our city really correspond and correlate to chronic diseases in our city, especially around cancer and especially around heart disease. What is really probably most prevalent for us is that we implemented several years ago virtual supermarket, which delivers over 6,000 online orders to 10 senior centers around the city for FY19. We redesigned our Healthy Stores, which was a program that we used to address healthy food priority in terms of food access of healthy foods from our corner stores. So we have 29 corner stores now, and that we've built relationships with those retailers to do nutrition education as well as to supply those stores with healthy foods. Now, those healthy foods are all really based in categories around our SNAP benefits. The next thing is Nutrition Ed, which is our brand new program. So as you saw on the maps, we will be identifying certain neighborhoods to do nutrition education in. And nutrition education will be what is the impact of food on the body, what foods can I prepare for myself, and how do I teach children how to eat. The next one is Tobacco Free Baltimore. And so, as you all know, on October 1st, 2019, our city went to 21 and under, where we are not allowed to sell tobacco products to. And so, because of that focus, we did over 650 tobacco compliance checks of 1,600 tobacco retailers here in the city. We visited 1,100 retailers to even talk about the laws, so you all know that in our city you are not to sell loose cigarettes, but obviously that continues to be a challenge here for us. The other piece of it is that when we do an educational visit, we educate on the law, but we also educate that we can fine you if you are in fact in conflict with the laws, which is unpackaged cigarettes and selling to those folks under 21 and under. In FY19, we were able to provide education, prevention education, secondhand smoke, e-cig education to 6,572 children in Baltimore City schools, rec centers, and 13,549 adults through community events as well as to presentations. It gives us a total of over 20,000 people that we impacted through the city around cigarettes and tobacco control. And so first of all, we had a couple of collaborations with, in order for us to do our job, which I want to publicly thank you to the Baltimore City Health Department Environmental Health, who works with us around tobacco enforcement, and the Baltimore City Health Department, the Baltimore City Police Department, who assist us with helping us with finding our tobacco retailers who are not in compliance with the state laws. And so now I will turn it over to my colleague who will talk about asthma.
Good morning. I'm Margaret Schnitzer, the Director of the Community Asthma Programs at the Baltimore City Health Department. So the Baltimore City Health Department provides direct services to the families of children who have moderate to severe asthma. We also provide community-based education for direct caregivers as well as professional caregivers. And we also do coalition building across the city for individuals who are interested in asthma and interested in making an impact on asthma. So the in-home intervention we provide is a multi-component, home-based, multi-trigger intervention for children under the age of 18. It is evidence-based. It started in Seattle-King County about 10 years ago, and it has been shown to bring about a reduction in asthma symptom days and asthma symptom nights, in emergency room visits, and in hospitalizations. It's very important that it has those positive outcomes because asthma has a huge impact on day-to-day lives of not only the children that have asthma, but their parents as well. So asthma has been shown to be the leading cause of school absenteeism, and you can attribute approximately 14 million missed work days to asthma. So it's got a huge impact across the country. We are funded here in the city through two mechanisms. One is Medicaid CHIP administrative funds that allows us to serve children who are Medicaid eligible to provide this in-home intervention. That's not only in Baltimore City, but that's 8 other jurisdictions across the state. We're just about the only state in the country that has this capacity through this funding mechanism. The other way we're funded is through Title V funds through the state health department that runs through our maternal and child health department, and they provide it, they kind of subgrant it to us to provide this direct intervention. These two programs allow us to see about 450 children every year who have moderate to severe asthma. It's a lot of kids. Just to let you know what it is we do once we get in the house, we use community health workers, shown to be a very, very effective intervention. Each child gets between 3 and 6 home visits, depending on the family need. We provide kind of basic asthma 101 education, which providers don't often have the chance to give when kids are seeing their doctors. We provide training for medication technique, because the technique of how you take your meds with asthma is critical to being able to control your disease. We also provide case management, because what we have learned over the years is we have to help families kind of deal with the other stresses in their lives that are preventing them from dealing with their children's asthma. So we provide case management around those issues for families so we can then help them manage their child's asthma. So it's really much more comprehensive than simply asthma. We do advocacy. A lot of advocacy is around housing issues. Since asthma is such an environmentally triggered disease, we have to make sure the child is living in a healthy environment. We communicate with their child's doctor, so we are closing the loop so the doctor knows, hey, this is what's going on in the child's home, this is what's really happening. And finally, and not least, we provide supplies to help mitigate the asthma triggers in the child's home. So we give things like green cleaning kits so their kids are not triggered by bleach. We give integrated pest management supplies so the roaches and mice that can trigger asthma are not in the home. We give mattress covers and pillow covers that are allergen proof so that kids are not exposed to their dust mite triggers when they're sleeping. So that's our programs.
Okay.
So that wraps up our presentation on chronic disease. I didn't know if you all had any questions you wanted to follow up with.
So I'll go Councilman Clark, and then I have a series of questions as well. Go ahead, Councilman.
I was just wondering how you identify the 450 children that are part of this program, and where they, how you find them.
We do it in several different ways. We get lists from Medicaid about every 3 months that let us know the 8,500 kids in Baltimore City that they consider to be at high risk for asthma morbidity. We start to reach out to the kids who have the highest morbidity and at the highest risk. Send letters, make phone calls. We also partner with providers, emergency rooms, MCOs, Head Starts, Judy centers, schools. We work with school health internally in the health department. Really anywhere you would come in contact with kids who have asthma. And then we do community outreach through health fairs.
So basically, excuse me, there are 8,500 children in the city that you consider to be at risk because of asthma.
Correct.
And we're
At any one time. It's a slightly shifting list.
yeah.
Yeah.
And then there's 450 children who are part of this intensive, at least it sounds, I hope, intensive oversight program and case management. So what is the capacity of this program?
Well, our capacity, given the current funding levels and staffing, is 450
That's
kids.
what
yeah.
That's how you're
Yes.
determining that
Yeah.
you could get more, and most of your funding is through.
Well, it's a combination. Most of it is through the state Medicaid, those CHIP administrative funds.
What's the budget?
From that,
It's okay if you don't know.
yeah, I don't know the exact number, truthfully.
But I'd like to. I think
I'll get
we
that
would
for you.
like to have that information.
Yeah, if you could provide that to the committee.
Thank you. Thanks.
So on this, so you mentioned seemingly a focus on young people. Is there outreach to older adults, seniors that may be living with asthma?
We do not. As people age, comorbidities that would affect their asthma gets very, very medically complicated. So we don't provide the same kind of service to older adults. We do, and can have the opportunity to do kind of much more general group education about asthma management. And also, as we're teaching the parents about asthma, because asthma also has a genetic component, the parents are learning about their own asthma, and sometimes it's grandma who is the caregiver who's learning about her own asthma. So we don't do, and because of our funding streams, it's really our direct services are focused on children.
Okay. Are there partner organizations that may do this work, or have any capacity to do that kind of work?
Well, we've worked with chronic disease internally. Not really. The MCOs, I think, do some work with their own clients, their own patients who are at high risk for asthma morbidity. But again, as you age, it gets much more complicated.
Got it.
Yeah.
Okay. I did have a few questions for Darcy, the chief epidemiologist. Felon Hemrick, sorry. Didn't want to mess up your last name. So can you, we looked at you showed us maps, and it sort of overlay, I'm guessing economic data. Is there a connection with healthcare access as it relates to chronic disease? I was just trying to figure out like why these maps look so similar when whether we're talking about blight, we're talking about violence. It's literally the same neighborhoods. Am I answering my own question here?
So I think we do see similarities in the maps across so many different health outcomes, and I believe it's probably due to a wide variety of reasons. We do have federally qualified health centers in a lot of the communities, which I think helps to improve access to care. But I believe a lot of it has to do with the social determinants of health, like poverty, education, employment, housing, transportation, and so forth.
And the other question I had around this, it sort of relates to the geography. You mentioned the racial disparity. Is that due to, there's a lot of conversation about predispositions and genetics. Can you speak to the connection there that may also contribute to the disparities we're seeing by race and gender? Or sex?
Just to understand your question, so you're asking about any genetic differences that might account for the life expectancy differences that we see?
Or predispositions to certain chronic diseases?
Yeah. I don't know a lot about that exactly. I think much of those differences in life expectancy are driven by the social determinants of health, but actually our Chief Medical Officer, Dr. Shelley Chu, sounds like she could answer your question.
Cool, thank you.
Good morning. Thank you so much for having me. Thank you, Darcy, for your great presentation. And discussing about race and gender, there is really good literature, especially when it comes to race, and it's really racism and the effects of racism on one's body, and it's really the allostatic load and the chronic stress of facing racism and structural and institutional racism every day. And that literature has been really strong when it comes to maternal and child health. That literature is more emerging in chronic diseases as well. But as Dr. Phelan Emmerich was saying too, there's so many components as well, including the social determinants of health, poverty, housing, food insecurity as well, but they all play together. And so there's no one simple fix. It's really just a big sort of complex solutions for complex issues that have been occurring for hundreds of years.
Councilwoman Clark?
This is the map we've been looking at for as long as I've been a member of the City Council, and that goes back to 1975. And in that time, in the late 90s, hundreds of people in that afflicted map had the public housing, the high rises were demolished, and they were rebuilt in different ways, more neighborhood oriented, at least on the Lexington Terrace side, but really everywhere, on the east side as well. Right now we're undergoing a huge renovation, reconstruction of public housing. I'm talking about income levels here. But I don't see the map changing at all. In other words, the housing has changed I think for the better. Lord knows it couldn't have been worse than it was with the old high rises. And they're all gone and have been replaced, certainly with at least architecturally or better locations. It doesn't seem to make a difference. So and you still need to do it, and maybe it's the maintenance, or maybe that housing wasn't done right anyway for health reasons. I'm just talking right now about your health.
Yeah.
But what is it that, is it it just plain income that is going to make the difference?
That's a really great point that you've mentioned, and I think it has to be a combination of things because it's so complex.
What's the driving force, though? It's not, I mean, I look at that, all the millions of dollars, well deserved. I mean, it was a mess in those high rises. I remember well pushing trash down chutes with people.
Yeah.
It was gross.
Yeah.
But so hundreds of people in that map have better housing than they did. All right. But it doesn't make a difference. So what does? It seems to me what you say about racism is, one, first of all, absolutely what we're looking at. And then, so then it's got to be poverty, too.
I think poverty absolutely
Related to racism, related to income and education.
I would also mention that for those hundreds of lives who've been seems like very positively affected, sort of that human story on the individual level, that's also really important. And then for mortality rates are mostly going down. And then for the maps, I mean, we're looking at an aggregate population level as well. So in Baltimore City, we have 600,000 individuals. And when Dr. Phelan Emmerich looks at those maps, I mean, they're in the CSAs, but they're still with thousands of individuals in those maps. So when you're looking at these maps, sometimes that needle shift, it's not moving as quickly as we want to. But I think for all the work that City Council has been doing, we've been doing as well, I also don't want to discount the really great work that's happening on the individual level that's really meaningful for those families as well. And any type of positive change, whether it's increasing their quality of housing or actually providing housing, it's very meaningful to the family. And just because the data hasn't caught up to what we're seeing on the ground level, I don't want us to become discouraged about the good work that we've been doing and what the health department team has been doing as well.
I'm not trying to minimize what the health department is doing at all. I think the health department's basically more and more, the health department is our way to success overall.
Yeah.
And I also believe very strongly that who saves one life saves the earth entire. So I didn't make that up. It comes out of a Jewish heritage amongst the wise Rebbes. So yeah. Who saves one life saves the earth.
Yeah.
But I'm looking at a map right now this morning and wondering,
Yeah.
I'd like that map to fade
Yes.
in my life.
Oh, we're with you. Yes, we're with
And I'm,
you.
like one of your elders, so that means we gotta hurry up.
We're covering the elders next.
Oh, okay.
There's a hearing on, or
But
discussion on aging.
but the health department is, in my book, the health department is where we are in the 21st century, leading, that health leads. And once from the trauma to everything else that we know, that you're the leading agency and people for our future.
Thank you.
Yeah.
Councilman Reisinger?
Thank you, Mr. Chairman. I just want to piggyback on regards to my colleague, regards to poverty. What about the health department when it comes to the homeless with some of these encampments that they go to, the wraparound service? Is the health department working with these homeless people also if they have asthma or medical conditions?
Sure, that's a good question, Councilman. I would need to get back to you, and I'll talk to our staff and
We don't,
follow
I'm not
up.
being rude, we don't know whether we're helping, the health department's helping homeless people or health care for the homeless, yeah.
Sure. So, and I'll bring Dr. Chu back up, but we can also follow up with a more thorough answer. I also know that, we're working with MOHS as well on that front.
Yes, we've been we work with Healthcare Access Maryland
Okay.
for care coordinate with community health workers and care coordinators. And so some of the patients and the residents that we do see, they are experiencing housing instability. Some of them are homeless as well. And along with that work, we do work with the Mayor's Office of
Yeah.
Homeless Services.
I mean,
as well.
also, my other question is, in my district, I mean, you have women, mothers, single parents who have a couple of kids. They may be working 2 jobs or 1 job part-time. How's the health department work with them on?
I'm so glad you asked that question. So as a mom of 2 young children, my youngest one is 11 months and my oldest one is 3 years old, and I started with Be More for Healthy Babies as their senior medical advisor. We have a really strong, robust maternal and child health program with Be More for Healthy Babies. They also work with Healthcare Access Maryland to provide care coordination, and there is a centralized care coordination unit. And so that anyone who is on medical assistance through their first prenatal visit, there is a referral that is sent to Healthcare Access Maryland. And from there, community health workers, they link families to the social service supports that are needed, also to home visiting programs as well. So there is a robust set of services that are provided.
So, regards to the budget, the large percentage, the majority of your money comes from federal, state, or grants. How much do you get from the city when it comes to the general fund? It's not much.
Not too sure.
I apologize, Councilman. We'd actually need to follow up with you to get you those numbers.
Okay,
But
you send
I
it
can
to
get
the
back to you on that,
chair.
yeah.
you'll-
Yeah, if you could send it.
Break
in
that
there.
down. Yeah. Oh, Doug.
Councilwoman Clark?
Thank you, Mr. Chairman. This is just based on something you just said. When they dismantled the health department, the Waxter Center, the Commission on Aging, when they dismantled that back in, I think, Mayor Stephanie Rawlings Blake's administration, the first thing they did was try to put it into Healthcare Access Maryland. In other words, the first move was to, as I recall it, was to take the Commission on Aging and Retirement Education, which was an agency, and transfer it into Healthcare Access. Then somehow that didn't work. Duh. And then they moved it into the health department, our health department. But as you mentioned, Healthcare Access Maryland, which was locally around here, and I don't know if it still is, how much of what you're doing in the health department is still done through that agency? Is it still part of the old Commission on Aging and Retirement Education? Do we still have part of that?
Councilman, are you speaking specifically to the Division on Aging and Care Services or Healthcare Access Maryland?
I'm talking about Healthcare Access Maryland.
Okay.
That was the first stop when they dismantled the Baltimore City Commission on Aging and Retirement Education. It was to save money. And so in went the commission, and shortly thereafter, not long after, somehow they couldn't handle it, or they weren't eligible, or I don't know what happened. But then more of it, most of the commission moved into the health department and became a division of the health department. I'm just wondering, I know that. What I don't know is, are we still entangled in or working with, in some way, the Healthcare Access Maryland?
Yes, so we are working with Healthcare Access Maryland, especially as it relates to care coordination for young families, and then also through a grant called Accountable Health Communities as well. But I think this is a
Yeah, and without Councilman, without going too far into it, the next portion of this hearing will be aging specific.
A whole
So we
presentation
can
on
do a
aging
much
coming up.
deeper dive.
Oh, I thought this was it.
Oh, no.
Oh, no, sorry, we actually,
well,
I apologize.
I just-
Let me
We have another
say that
slideshow.
I have nothing against that agency, but they were always, seemed to me, to specialize in young people. And that's why it was like, duh, when the Commission on Aging tried to fit in there. But it's not there I know it's not there anymore, but we're still working with them and youth and things like that, right? And that's fine, I mean,
Okay.
that's what they do.
Yeah.
Thanks.
All right. Any other questions related to chronic disease?
I gotta go pretty soon.
Okay. I actually did have one, just a small one, on natural causes. Didn't see that on there. How is that defined? And how does that fit into sort of the other category of deaths in Baltimore that you had on the chart?
So thanks for your question. When a person dies, the manner of death is determined. So that's different from the cause of death.
Okay.
And so natural causes is a manner of death. So the manner of deaths include natural causes, accidental, homicide, suicide, and undetermined. So natural causes of death really speaks to it was just the natural course of disease for which the person passed away from.
Got it. Okay. Thank you for that. All right. So we're going to move on to the presentation for aging.
Yep, we have Deputy Commissioner Heung Tan, who's going to present for the Aging Division. If I could make one request, Councilman, if there are no other questions for the chronic disease crew, if you wouldn't mind if we could send them back to the Health Department. They've got some later morning meetings.
I don't have any more questions, and I'm gonna have to leave myself pretty soon for a meeting.
Wonderful.
We're good.
Apologies in advance.
Thank you, and thank you for the opportunity from that team.
Thank you.
Sitting there by himself.
Good morning.
Good morning.
Good morning, Mr. Chairman, honorable members of the Health Committee and the Mayor's Office. I'm pleased to be here this morning to provide information and present on behalf of the Baltimore City Health Department under the leadership of Baltimore City Commissioner of Health, Dr. Letitia Sharasa. As mentioned earlier, my name is Heung Tan, and I have the privilege of serving as the Deputy Commissioner of Aging and Care Services. And in this capacity, I also serve as Baltimore City's Area Agency on Aging Director. Before I get started, I wanted to acknowledge members who are here today in our audience, our partners, and our acting co-chair for the Commission on Aging, Ms. Betsy Simon, in addition to the many members of my team at Aging Services who are here today to answer any questions that the committee may have. In my presentation this morning, I plan to provide a brief overview of 3 areas. One, services available to older adults here in the city. Second, health trends of people 60 and over. And then lastly, highlight some of our major initiatives that we plan to tackle this year. For Baltimore City, the Area Agency on Aging is housed in the local health department. We're a handful of Area Agency on Aging in the country that operates under the authority of the local health department. This arrangement is rather unique in the fact that nationally, people are looking at Baltimore City in terms of a service delivery model and the intersection of public health and aging. I can attest firsthand that I serve on the National Board of Area Agency on Aging and represent the Mid-Atlantic region for Baltimore City, and I can tell you that my colleagues in the field are looking at new ways to support and sustain programming for this very fast-growing population. They're looking at Baltimore City for models of service delivery in addition to advocacy. Our mission, vision, and provision of service under the Older American Act is simply stated. We are here to help people who are 60 and over to live their best life possible wherever they are in their life course, whether it's at home, alone, home with community support or in the long-term care facility. We do this work with compassion and a relentless commitment to protect and serve, while recognizing that this population has still so much to give and continues to give to the city. Under these 5 service areas, we provide roughly about 30 programs to support older adults throughout their life course. Councilwoman Mary Pat Clark, I think you had asked what services at the health department, aging plays a role. We are a third of the health department's programming. The health department has a mission to serve every individual throughout their life course, from birth to throughout their life. And this division of aging and care services does just that through these 5 service areas. First, advocacy services. We think of it as programs of point of entrance, connecting people and advocating for people. Highlighting under this program area includes the Maryland Access Point, which I think a lot of folks know about, is a 24-hour call center available for older adults. And our information and referral assistance workers are here to provide options counseling, benefit checkups, information, and referrals. They handle about 26,000 calls annually, and we are one of 8 call centers nationally, thanks to the partnership of United Way 2-on-1, that is available to our city residents 24 hours. Second service area that we're moving towards is community services. This service area focuses on all programs to support individuals in the community. This includes transportation, falls and chronic disease prevention, congregate and home delivered meals, as well as support for caregivers and grandparents who serve as primary caregivers. Last year alone, we were able to provide 400,000 meals to individuals and subsidized taxi service to 5,000 older adults and people with disabilities. Senior centers, which I will discuss in the next slide. The next service area is home and community-based services, formerly known as adult geriatric health services. This office staffs nearly 45 community health nurses and support planners, all assigned to help older adults age in place in the community or at home. Client services, our last service area. This service area provides support for our most vulnerable clients who are chronically ill, cognitively impaired, and have disabilities of one or more. This includes the public guardianship program, which I serve as the legal guardian on behalf of Baltimore City for 200 clients who are 65 and over. For those of you who are caregivers for your aging parents, you know that this type of care is round-the-clock care, and the team at the guardianship program provides such that. This next slide highlights all of the 13 senior centers here in the city, broken down by council district. We have 13 centers in the city. The Baltimore City Health Department operates 7, and we support the other 6 nonprofits through grant funding and technical assistance. Centers are focal points in the community. Our senior center directors provide not only programming each and every day, but they provide access points to services as well as nutrition, information, and support. These centers are vital in helping older adults age in place, in addition to helping support socialization. Next, and I'm happy to answer any questions around service areas. At the end of my presentation, I'm highlighting some of the trends that we're seeing of people 60 and over. Here we look at the overall population, which gives us a glimpse of where older adults are aging in place. As mentioned earlier, this age group of 60 and over is the fastest growing population, not only in our city, but in our country. It's predicted that by 2030, Maryland state population of 60 and over is expected to grow by 30%. And Baltimore City is expected to remain among the top 5 counties in the state to have the largest population of 60 and over. Sorry, there's one more thing I wanted to highlight based on this map here. It's broken down by districts, and districts 5, 6, and 8 have the largest population of residents who have residents 60 and over. Districts 2, 6, and 4 have the largest number of individuals who are 45 and 59. So over the next 15 years, we'll see individuals aging in place in these districts, and they'll see the largest growth trends in the city. This next graph looks at poverty rates of individuals 60 and over. It's important to note that Baltimore City residents make up nearly a fifth of the state's population of people who are living at or below poverty level. As a result of this, we find that older adults really need safety net programs and investment in more safety net programs such as transportation, nutrition, housing to help their daily needs. I'm going to go rather quickly through these slides because my colleagues in chronic disease touched upon some of the slides already. This next graph, excuse me. This next graph shows life expectancy broken down by neighborhood. We all know that where you live matters because it determines how long you live. In this map, life expectancy is broken down by district and neighborhoods. The life expectancy of individuals for Baltimore City, as mentioned earlier, is 73 years old, compared to the state's life expectancy of 79.2 years. There's at least a 5-year difference in life expectancy between our white residents and our black residents. And you'll see in the graph that our team here has broken it down by districts in terms of the life expectancy at birth. Here are two graphs that focuses on individuals living alone and with disabilities. We're concerned about this because people who are living alone and with people with disabilities have the highest health risk. Researchers have found that loneliness is just as lethal as smoking 15 cigarettes a day. Lonely people are 50% more likely to die prematurely than those with healthy social relationships. With this, we are concerned that we are focused on programs that bring people together and focus on social isolation and community support, and ask that programs such as hubs and Maryland Access Points and other aging programs are supported at the level that they need to be supported. My colleagues at Chronic Disease touched upon the leading causes of death, but here are the leading causes of death for people over 60 and over. My apologies, my slides are not in order. The top 5 leading causes of death for Baltimore City residents aged 65 and over are all chronic diseases. They include heart disease, cancer, cerebral vascular diseases, other respiratory diseases, including diabetes. It's important to note that not only do we, at this age group, do we need to work on preventing chronic disease and its complications, but we also need to focus, and this is where we work really hard to focus on stabilizing the individual's life, health. Another growing trend that you'll notice is the onset and increase of STDs amongst older adults. Here are the top 3 rates of rising STDs in older adults. I think one of the things that you'll note is that's not seen on this graph is that as rising STD rates are going higher, our rates of people with healthcare access has decreased over the last 5 years. Less than 1% of Baltimore City residents 65 and over uninsured, thanks to programs like the Senior Health Information Program and the Maryland Access Point. This year alone, we were able to help 7,000 Medicare eligible residents enroll. Another growing trend that is a concern that we're looking at and looking for programming and providing support for is Alzheimer's. There is an 8.6% increase in Alzheimer's-related death in the city, and then what we find also as a notable trend is African Americans are twice as likely to develop Alzheimer's than their white counterparts. As such, the health department has applied for some grants in addition to a CDC grant initiative to focus on brain health. The last growing trend that I'd like to highlight is elder abuse. I believe my colleague here will discuss a little bit about elder abuse, but there is a growing number of elder abuse these are reported cases in the state, 7,400 reported cases. And what we're also seeing is an increased number of unlicensed facilities in the city. There are about 400 assisted licensed facilities, but we estimate that there are double that of unlicensed facilities. The long-term ombudsman program that focuses on investigates potential abuse and neglect. Last year alone investigated over 700 cases in these long-term care facilities. It's also estimated that the increase of financial exploitation among family members have increased. There was a case this year where we were able to assist a 100-year-old client who was being exploited by her family member. Through our senior legal services program, we were able to revoke the daughter's financial power of attorney and recover nearly $20,000 back for the client. My colleagues in chronic disease touched upon a little bit around food priority access areas, so I'm not going to touch a lot on it, but 25% of older adults live in food priority areas, and we are really focused on providing services around nutritional services here, particularly helping older adults access SNAP benefits. There is a low number of enrollment here in the city. Next, to the third piece of the presentation, I'm going to focus on some of the key initiatives that we're focusing on. This year, we're focusing on launching a citywide aging framework that focuses on 3 goals. Some of the trends that we had discussed, really, our goals focuses on those things. The first is to facilitate independent living, essentially focusing and doubling down on the social determinants of health, housing, transportation, food access. The second goal focuses on promoting good health and quality of care through increasing access. And at the health department, we really focus on this through a systems approach and providing coordinated care through that. And the third piece is cultivating a collaborative advocacy effort, strengthening leadership in advocacy for older adults, in addition to embedding aging in all policy development. I touched upon this initiative earlier as I talked about the systems approach in increasing access to care is this ecosystem of service delivery that we're creating. Thanks to the support of the Weinberg Foundation and our partnership with United Way 2-in-1, we're expanding access to services by connecting older adults to social needs such as housing, transportation, and legal services through enhancing our technology infrastructure and providing real-time capacity updates around resources and care coordination. We touched upon falls prevention earlier when we talked about injuries, but falls is the leading cause of fatal and non-fatal injuries for older adults. It takes, as you know, it takes just one fall to change the life course of an older adult and take away its independence, his or her independence and health. This map shows the rate of falls per 100 people by census tract. One of the unique initiatives that we have here at the Baltimore City Health Department is the Befriend initiative that is able to pull real-time data to really find where the falls hotspots are in the city. Here in the map, you'll find, this map was just pulled this week. Here you'll see in the map that the highest rates of falls are in the Mount Washington, Cold Spring area, Bel Air, Edison, Southwest Baltimore, Roland Park areas of the city, and Loch Raven. We touch around nutrition. Through our partnership with Meals on Wheels, we're able to provide and expand nutrition services for older adults. And lastly, one of the things that we're focused on this year is the Census 2020, our ongoing efforts to support a citywide effort to make sure that every older adult is counted. Our funding through the Older Americans Act is tied proportionally to the number of people living here in the city. So it's important that we make sure that every person is counted. One of the challenges that we also see is that the census is online. So as such, each one of our senior centers is equipped and will serve as access point for census work. That is it for my presentation for now. I'm happy to answer any questions, or my colleagues here are happy to answer any questions.
Okay, thank you. So I had a few. Related to the unlicensed senior centers, what is the best way for council members, council staff to confirm if a center is licensed or not? And if we do find that information, where does it get reported to? Like, this has come up a few times, not just related to senior centers, but we've had questions about licensing related to residential treatment facilities, et cetera. Group homes.
So,
yeah.
So that's a really good question. I think I wanted to provide some clarity. We do not provide licensing to assisted living facilities. It's through the state, the Office of Healthcare Quality. Our job is really to investigate any elder abuse or neglect cases within the long-term care facilities. If you suspect an unlicensed facility, I would report it to the Office of Healthcare Quality, or I would actually just call our 396 care number, which is our Maryland access point, and they will refer you directly to the Office of Healthcare Quality in order to do that.
And would the same apply for residential treatment facility? Like, do they cover just aging, or is that any sort of?
The Office of Healthcare Quality does that as well.
Okay. You got a follow up on that?
Yeah, following up on that, I'm trying to think if there's a tactful way to ask what kind of response do you see from the state when people bring those kind of allegations? How many instances are you aware of where the state has actually closed a facility that was operating without a license?
I'm looking back there for my colleague who works who's our long-term long-term care manager, and she actually had to step out. I'm happy to provide a response in writing to you as a follow-up, but we work very closely with the state on that issue, and they take our investigation and our notes very seriously.
Okay, so when you are following up on allegations of elder abuse and you do an investigation, the state takes your investigation seriously.
Yes.
But if a community member calls to your and the state's attention that there is an unlicensed facility operating,
so there are two
does it get
things.
shut down because it's not licensed?
So it's very difficult to shut down a facility in general, whether it's licensed or an unlicensed facility. What ends up happening from what I know is that if you close Mrs. Jones' 8-person shop in their home, you'll find that they'll open up another one, probably the street next to it. So it's very hard to kind of chase that. But one of the things is that we do report it to the Office of Healthcare Quality, and they are diligent around visiting and investigating those instances.
Yeah, I think that's something we definitely would like some follow up on that piece, because I do get those calls, and it is difficult to even navigate on this side of it. So I think that would be helpful to and also just to know what type of information we should be gathering, what do we need, like what constitutes, well, I guess we'll have a presentation on abuse, but, you know, what are the types of things that we should be prepared to provide
So
other than like.
one of the
we think-
things is that if you call our Maryland Access Point, it will defer to the Long-Term Care Ombudsman Program, and all we need really is an address. We don't even need a specific resident's name, because I will tell you that we have received calls where they're scared of reporting this because they're you're reporting a potential abuse against the primary caregiver, and a lot of the times is that you don't have anywhere else to put your loved ones if you shut this place down. And so we do it very carefully and very tactically. So what we do is we just visit the location. Give us a location, we'll send someone out within 24 hours and we will investigate. If they do not let us in, then we pull the state and the police as such. So that's the first step, is give us a location. You don't even have to give the name of the resident that's living there.
Okay. The other question I had was around the senior centers. As you can see, they're sort of sparse throughout the city. Can you talk about the agency's relationship with recreation and parks?
Sure. I'm happy to. Let me
and-
pull that graph.
Yeah, so it's not many. And then we've had hearings on this topic before, discussions on this topic before in the budget committee around how do we
So-
grow these out, especially given that you've indicated it's the fastest growing population in the
So
city.
Rec and Parks has a senior division within their agency. We work very closely with their senior division. Their senior division is actually housed right at our John Booth Senior Center. And they operate two of our centers for us, which is the Cherry Hill Center in addition to the John Booth Center at this point. We we have different memo of understandings in different areas, but they either provide recreational support, but they follow the flow of what is needed within each senior center program guideline.
Okay, and I'll reach out to them because I do have questions about programming, especially with the expansion of hours and rec centers. I mean, I think that's going to be, you know, a continued push is to keep these open as often as possible. Weekends, you know, we have Saturdays now, and I do know that sometimes the centers themselves have struggled with programming ideas, and this is more on like the center director level. So I think there's an opportunity here that, you know, when we think about recreational facilities, we think about mostly kids, but I think these are great spaces that, you know, can be used for older adults, often are used for older adults, but need a little more creativity on the rec director side. This is not your problem, but I just think that we can, you know, as people continue to age in place or push for aging in place, these are spaces that they should consider, especially the intergenerational aspect as well of having young people and older adults in the same facilities, working together, learning together, playing together. That socialization piece, I think, is critical. But I'll reach out to the senior.
We work very closely with Rec and Parks, even just on a strategy level of looking at every center right now, trying to figure out how do we maximize our resources that we currently have and serve older adults. So I'm happy to kind of be part of that discussion as well.
And the last question I had, and before Henry had anything, the Alzheimer's and the connection with Alzheimer's and memory issues related to that. Is there a connection between sort of the outcomes of not really remembering to take your medication or anything else that could contribute to the increase in chronic diseases that we see in older adults? Are there connections there?
I'm looking at Shelley. Shelley, do you think you could answer that question? I'm sorry. You know, there is complications of chronic disease, but I am not a medical provider, so.
Can you repeat the question one more time for me?
So the link, is there a link between the impact of chronic disease on someone that has Alzheimer's? Like, do you find that there's a sort of over-representation of other outcomes of whatever other disease they may have because of the Alzheimer's? Maybe they're forgetting to take medication, that kind of thing.
Yes, that's a great question. Thank you so much for asking that. Absolutely, there is a link, especially with Alzheimer's, it can exacerbate other comorbidities as well. I think a part of it is due to being able to take care of yourself, such as your medications, and then all the activities that is needed for care for the individual. So yes, these are all, I guess, these are all complicated in terms of they're complex and they're all intermingled together. And so one disease affects another disease, and they do exacerbate the conditions.
And what are some ways that either the health department or other service providers sort of account for that when working with people who have Alzheimer's?
When it comes to Alzheimer's, I think it's really looking at the patient as really as a whole too, of just, we can't be treating a patient just on one condition, just looking at, from the neck up or just only from the neck down as well. And so really keeping in mind of the person as a whole, but then I think even broader than that, also sort of the social support that Deputy Commissioner had mentioned as well, and using resources that are available. So using family support if the individual has supports that are available, but then also pulling in sort of the primary care and the medical home, and using resources that are available through the care coordinators and social workers as well, but also really looking at a trauma-informed approach as well.
Currently, what we're doing is providing in-home care support for those who have dementia or Alzheimer's, and if they're eligible, provide adult day care support and caregiver support for those who are primary caregivers, because it's a lot of work.
Okay. And then the last question around aging in place, are we prepared from a housing perspective in the city of Baltimore to handle the growth of older adults? And you mentioned it was the fastest growing population in Baltimore. What more needs to be done at the local level, state and federal level to meet that demand?
I think when we were doing our development of our strategy, housing was the number one issue that older adults raised: affordable housing and housing in the place that is equipped to support an aging adult. I don't think the city is prepared, but it's a very it's a tough, complex question. There are a lot of initiatives that are being developed, and we're really thinking kind of outside of the box, and with the intersection of health and home, and focusing on bringing models like the SASH model, care coordination within these housing stocks, as well as there's an entire network of nonprofit groups that's supporting housing through the housing, what I had mentioned before, housing upgrades for Baltimore seniors, focusing on providing support and rehabilitation of buildings and putting handrails and focusing on repairs and ramps in the homes.
Okay. Any follow-up on that? Okay. Thank you. So our last presentation will be from Jackie Schroeder.
Good morning.
Good morning.
Thank you, Councilman Burnett, and members of the committee for inviting me to meet with you this morning. I'm really grateful for the opportunity to speak about Ghana's role in working to end elder abuse and what I see as the challenges facing our older adult population now and in the future. My name is Jackie Schroeder. I'm a licensed clinical social worker, the director of SAVE, Stop Abuse of Elders, a trained long-term care ombudsman, and the project coordinator for a federal grant from the Department of Justice focused on Baltimore City that I'll discuss in a few minutes. SAVE, Stop Abuse of Elders, is a program of Ghana and the Associated Jewish Community Federation of Baltimore. Ghana is a service provider that responds to victims of domestic violence, sexual abuse, elder abuse, and stalking. SAFE provides comprehensive intervention services to people age 50 and older who are community dwellers, meaning people who live anywhere other than in a nursing home or licensed assisted living facility. SAFE also offers prevention education to older adults and professionals and consultation services to victims, family members, and professionals. I need to be frank with you. 10 minutes is not enough to effectively cover the complex topic of elder abuse. It would take more than 10 minutes simply to list the challenges all of us face. So I'm going to tell you what elder abuse is and tell you what I think is the #1 priority for you to focus on. In addition to my testimony, I've provided you with that list of challenges, a fact sheet, and a power and control wheel for elder abuse for you to understand tactics used by abusers. And I look forward to meeting with you again to discuss the list of challenges. What is elder abuse? Elder abuse is a single or repeated act or lack of appropriate action occurring within any relationship where there is an expectation of trust, which causes harm or distress to an older person. For the abuser, it's all about gaining power and control over their victim. Irrespective of the type of abuse, elder abuse is an intentional it's an intentional act or failure to act. Again, the hallmark of all elder abuse is trust. It's trust of the abuser by the victim. Elder abuse occurs in all communities, regardless of socioeconomics, race, religion, gender, sexual identity, or culture. Elder abuse is different from domestic violence. Domestic violence is intimate partner violence. Elder abuse is intimate partner violence, but also abuse by family members and other trusted individuals. Elders can't just walk away, go to live on their own, or get a job and start their lives over. They are dependent on their abusers. So when attempting to aid a victim at SAFE, we encounter significant barriers related to housing, transportation, health, finances, mental health, cognitive impairment, substance abuse, socialization and isolation, insurance, food, and transportation. And all of this is compounded by additional factors ranging from elders' difficulty hearing over the telephone and their inability to understand how to navigate and execute the complexities of getting their needs met. Combined with the multiple effects from the audacity of elder abuse and a high demand for resources now and for the foreseeable future, we are all challenged to bring an end to this growing epidemic and to build communities that protect and respect our elders. 66% of people who abuse community-dwelling elders are family members. 47% of them are children and grandchildren. A victim of elder abuse is 300% more likely to die and more than twice as likely to go to a hospital emergency room for treatment, refuge, food, and replacement of stolen medication than an elder who is not mistreated. 42% of people over the age of 60 who are killed are murdered by family members. 24% of people over the age of 60 who are killed are murdered by spouses. From census data that I could find, there are approximately 186,000 adults over the age of 60, pull it down? Okay. Over the age of 60 living in our city. And current data from the National Center on Elder Abuse indicates that 1 in every 10 community-dwelling elders is a victim of abuse. So it's suspected also that elder abuse is significantly underreported. So how do these numbers translate? Potentially today, this day, there are 18,600 elders being abused right here in our own backyard. According to the Maryland Department of Aging, the number of adults over the age of 60, as Heung Tan said, is expected to increase 30% by 2030, and with it, significant increases in risks for elder abusers targeting older adults who are lonely and who have dementia and Alzheimer's. Ladies and gentlemen, we have a public health and human rights crisis, and we must prepare now. It's happening right under our noses, and yet it's a hidden problem. And there are many good reasons why people don't tell anyone about their abuse. And they rarely tell unless they're asked. So we have to learn how to ask in a sensitive, trauma-informed, and trauma-responsive way. Elder abuse victims need to know we will help them understand what will happen to them and their abuser if they report. And they won't have to make the journey to safety alone. As the older adult population is exploding, beyond the shadow of any doubt, the number one challenge faced by both elder abuse victims and their advocates and case managers is the absence of an integrated citywide system and resources for responding to victims who have the competency and capacity to make their own decisions and to meet their daily needs. These are people who do not qualify for adult protective services. We heighten the risk of harm, of death, by not giving immediate and critical attention to creating that system now. Having all of us invested in keeping our elders safe is crucial. I'd like you to consider this. You are 62 years old, and your partner calls you fat and stupid, takes your paycheck, puts you on an allowance, and monitors your phone calls. What are you going to do? Do you have any idea who to call? Because the vast majority of people don't know. And if you even thought to call Adult Protective Services, you wouldn't qualify. Or how about this? You're an 84-year-old man. Your spouse had cancer and died last year. Your adult son moved into your home and is stealing your Social Security check and your pension. Again, who would you call? Where would you turn for services? Elder abuse is not only a battered women's issue. On average, 1/3 to 1/2 of my clients are men. When SAFE launched in 2013 through a grant from the Maryland Department of Aging, we quickly learned that elder abuse cases are complex, costly, and necessitate carefully coordinated services. And we found that workers in organizations serving older adults are not educated to recognize elder abuse, to screen for it, or what to do if the screening of a competent person was positive. Most importantly, we discovered that no response system existed for those victims. We needed to change that in order to serve them, and we still do need to change that. Today, with a staff of 2.5 full-time employees, SAFE is still the only program in Baltimore serving victims who do not qualify for adult protective services. And a system of response still doesn't exist. But we've been working on it. In 2017, through a groundbreaking partnership, including SAFE, Baltimore Police Department, the Office of State's Attorney for Baltimore City, the Baltimore City Health Department Division of Aging and Care Services, Baltimore City Adult Protective Services, and the Circuit and District Courts for Baltimore City, Chana was awarded a 3-year grant from the Department of Justice, Office on Violence Against Women, OVW, to implement the Training and Enhanced Services to End Abuse in Later Life program. That grant ends this year. All grant partners receive training from technical assistance providers from OVW in order to form victim services and law enforcement training teams. In 2019, victim services cross-training was provided, and this year will be conducted basic and advanced law enforcement training. A collaborative community response team, a CCR, was formed, whose members include grant partners and all other organizations in Baltimore serving older adults. It meets quarterly to focus on improving agencies' policies, procedures, and practices in order to address elder abuse while working to create a seamless response to victims and survivors. As the project coordinator for the grant, I conducted a citywide assessment of older adults and all organizations serving them, to determine what is needed for older adults to be safe. The top 4 needs identified were an advocate case manager to help victims understand what will happen to them and their abuser if they report, and to make the journey with them from reporting to safety, affordable civil legal services, a help number to call 24 hours a day, and transitional housing and shelter. SAFE now has a full-time advocate case manager, a no-cost civil attorney through an amazing partnership with Maryland Legal Aid, where we have an elder abuse attorney dedicated in our office 3 days a week, a help number that is answered 8:30 to 7 p.m., Sunday through Friday, and 3 different shelter options, one in a long-term care facility, one in a community-based senior-friendly studio apartment we were able to build, and partnerships with 2 hotels downtown. The advocate case manager focuses her efforts in the 2 zip code communities from which Adult Protective Services receives the most reports of abuse. Chana submitted a 2-year continuation grant to further the work of the advocate. Notification of awards will be announced this coming October. SAFE can't do this alone. Older adults need you. They need all of us. Thank you very much.
Thank you. Councilmember Henry.
Yes, first of all, thank you very much, both for the testimony and the power wheel and the fact sheet, which I'm going to find very helpful. I'm trying to get some clarification on, is elder abuse a subset of domestic abuse?
It is not.
Okay, that's like, because I got the feeling that it's distinct, but I'm still not getting quite what distinguishes it. Because I'm listening to the individual examples, and I'm thinking this, some of it sounds like child abuse, some of it sounds like what I've, been, explained as domestic abuse. What makes elder abuse different?
So, domestic violence is intimate partner violence. That includes violence between spouses, lovers, and partners.
Okay.
So in probably 2011, Chana started getting calls from the House of Ruth saying, we have this older person, she's being abused by her son, and she has some frailties. We don't serve people who are not being abused by their partner, spouse, or lover. And we thought that elder abuse was domestic violence growing old until we started getting those calls from the House of Ruth. And when we did and started to work with those people, we quickly realized elder abuse is a whole other problem. It can include intimate partner violence. And even in that scenario, the violence between maybe even lifelong partners in a domestic violence dynamic, those dynamics change as people get older. Does that help?
It does. It does. And so, but it actually opens up a new line of things I'm curious about then, which is, it seems like the remedies are the same in terms of taking the victim out of that situation or taking the assailant,
the abuser.
The abuser, thank you. Sorry, taking the abuse. Like, it's, separation is key. Would there be any value to, rather than segmenting these, would there be value to expanding our definitions so that, because you've clarified what domestic abuse actually is. I thought domestic abuse was abuse happening inside the home. I was not aware that it literally means between partners. So I also already was seeing child abuse as a subset of domestic abuse in terms of if a parent or an older adult in a home is abusing a child. If somebody is abusing an elder, if somebody is abusing someone their own age. If there is abuse happening inside a home, would there be value to just having a category for that, such that one entity could work on all of that? And has any of what your organization done been about trying to lobby to expand the parameters of what adult protective services can address?
It's a really excellent question. Save Stop Abuse of Elders is a partner to a national alliance called the Spring Alliance, and they created the first elder abuse shelter program. They're 15 years old, and right now there are 18 shelter programs around the country in 13 different states. We have another shelter program here in Maryland, in Rockville, called Elder Safe. But Chana is, Safe is the one of about 3 shelter programs that are actually community-based. All of the other ones are located in nursing homes, and 2 of them are located right within Adult Protective Services. One is in Sonoma County, California, and one is in Delaware. And I know those programs, I visited those programs. I think expanding Adult Protective Services, that would take a lot of changes in law to include an elder abuse program that would not be limited by the same parameters as the mandates of Adult Protective Services, would be an excellent, excellent idea. Adult Protective Services is required to open and close cases within a certain period of time and to provide a certain amount of service. Our service averages 400 hours per victim. That's a lot of time. It's very complex, and we don't have any limits on how long we can serve them. We've served people over the phone in one conversation. 2 weeks is maybe like the next level of service, all the way to a year and a half. We have somebody in our safe house right now who's been there since August, and we've spent hundreds of hours providing services to her in order to help her have a new life. And actually, she came to us from an unlicensed facility. And I'd like to just answer further what I know from my feet on the ground experience of working with people who are caught in these homes. The Office of Healthcare Quality does not have any jurisdiction to go into a home that's unlicensed. What they can do, and I agree with Heung, I think contacting them is an excellent idea. They can knock on a door. If somebody answers the door, they can inform them that they're operating without a license. They give them an application to apply to get a license, which is not difficult, and they have 30 days to complete it and return it. But there's no follow-up. They never go back to that home. If someone...
Sorry, I'm going to interrupt to say that what you just described actually sounds a little horrifying, in that if it's easy to get a license and it's hard to enforce, it's hard to do anything to a place that doesn't have a license, then I'm unclear as to what is the value of the license, because if that would seem to imply that if a facility didn't do the things that they're supposed to do, the only recourse is to take away their license, at which point now we're back to the beginning of that circle.
I think it would be yes, it's horrifying.
Yeah, okay.
And it scares everything out of us when we get these calls. We do a lot of advocacy when we get those calls. We work with the fire department, who might put a cease and desist letter on a door. We call the police, who knock on the door, and if nobody answers, they have no authority to enter. There are a lot of barriers to helping people who are in these they're not even really assisted living facilities. And we've had experiences where people are being trafficked, and hospitals use placement agencies because they have to get older adults out of the hospital. Placement agencies, we've had the experience, have placed people with providers who are licensed, but who also have homes that are unlicensed. They might be across the street, they might be on the next block, they might be in the next neighborhood. And we don't have the resources to, for better funding, more staffing, and then looking at the laws. Like, I don't have enough time to be a legal advocate about this, but I think contacting the state ombudsman, contacting Mary Ann Brennan in the ombudsman office with Aging and Care Services, she was here earlier and had to leave. I think speaking with her about this matter is really critical.
Maybe this is, I guess, more of a housing department question, but how would the rental license program fit into this?
Yeah,
Are they considered renters if you're staying, whether it's licensed or unlicensed?
So this woman who's in our safe house now, the woman had her, she didn't have a contract, she didn't have a lease, she just was placed there, and the woman became her representative payee for her Social Security check. If she didn't like how our client was behaving, she threatened and followed through on not giving her food. She told that if she contacted anybody, she was gonna not feed her. She didn't feed her, those sorts of things. Something that I was told by one of the ombudsmen is that other jurisdictions are sending people into Baltimore City into these unlicensed homes because there aren't affordable homes in other jurisdictions. You know, what are you going to do if you get a $675 or $725 check every month from Social Security, and that is your only source of income? It's a terrible dilemma that we face, and a very, very unsafe dilemma, horrific dilemma.
What outreach is done to educate clients in licensed facilities? Obviously, the unlicensed ones is probably more difficult in, but is there outreach done, like sort of a know your rights training, workshops, that kind of thing? Obviously, you have 2.5 people, but among this, is that an element in this grant that you have with the health department and several other agencies to educate tenants or clients of licensed facilities on the signs of abuse and what to look out for ahead of reporting an experience themselves?
Thank you for asking that question. It's a tremendous focus of our program. We spend a lot of time training and providing consultation with organizations. We train seniors in all of the senior centers in Baltimore twice a year. We go into every senior apartment complex and we train the seniors what to look out for, how to say no, what scams are, how to respond when someone's attempting to scam them. We also train statewide. We've trained all of the ombudsmen. We've trained all of the adult service programs for Department of Social Services, not just Adult Protective Services. Last year, we gave this victim services training. There were 85 organizations in attendance. There were 120 people who applied, and some couldn't come. Last year, we got a Governor's Office of Crime Control and Prevention grant, where we spent a year and brought everyone together from across the whole state. And we had a day of learning about elder abuse, and we had breakout sessions. We're teaching people about bullying. Last year, we gave 43 presentations, and that is a huge part of what we do. I consider myself a huntress, if you will, because older adults are not going to tell. They're not going to tell because they're afraid that they're going to be killed. Their abusers are perhaps the only person that can give them food and get them to medical appointments, provide transportation, so they have to be asked. And so little by little, as our program is aging, we started in 2013. We started with 25 clients the first year. Last year, we served 120. And little by little, it's increasing. But 120 clients at an average of 400 hours per client, now we have 2.5 staff. In the beginning, it was just me, and then we became 1.5. Now Dorothy Allen is our amazing elder abuse advocate. so our next full-time person. But even with that, Adult Protective Services is now telling people to call us. So I received a text from the manager of APS to ask her about their numbers. And she told me that last year they investigated 1,220 cases. I asked her how many calls they received, how many reports. She said she didn't have that number offhand, and she was in a meeting.
If you can,
So-
you can send it later to the committee, and we'll get it out to the committee.
Say it again.
I said you can send it over email. We'll get it out to the committee.
I'm sorry.
It's that. So I was saying you can send it over email if she does have it later.
Okay,
and
great.
we can distribute it to the committee.
Okay, that sounds great.
Okay. I didn't have any other questions. I want to thank you for all you do, and thank you for this presentation.
Thank you again so much for inviting us.
Thank you. Anyone else sign up to testify? Okay. All right. This hearing, will there be no further business? The hearing is concluded. Thank you all for attending.